Good day, my name is Imelda Williams. With this presentation, I'm going to focus on abnormal radiographic appearances, and this will include the shoulder girdle and the upper limb. This is part A of this presentation, and in this part A, I will be focusing on the shoulder, the humerus, and the elbow. This lecture is linked to Learning Outcomes 3 and 4. And you should apply logical method to the accurate interpretation of normal and abnormal radiographic appearances of the upper limb and shoulder girdle, as in the emergency and trauma context. General informed opinions about radiographic images of common conditions affecting the upper limb and shoulder girdle in the emergency and trauma context. And then also that you should be able to identify pediatric considerations. Another important aspect I'm going to mention is the Gartland classification when we get to the elbow. Now, I've provided all of the references here, so the references are for both Part A as well as Part B, and you can see in the electronic resources that we have Bontrager, it's chapters 4 and 5. In Chan, it's chapters 2, 3, 4, and 16. In Raby, it's chapters 2, 6, 7, 8, 9, and 10. And then in the Advanced Image Interpretation Manual, I've given the pages for the wrist and hand, elbow, and forearm, and shoulder, and girdle. Now, I've also recommended some other resources. This is just additional. One resource that I have used, but I've included what I thought was necessary in terms of some of the imaging, is Greenspan and Beltran. And chapters 4, 5, 6, and 7 is applicable to this presentation. Now, I've given here a number of images, and I would like to encourage you to try and identify the radiographic anatomy. I will provide feedback on these after we have done a practice bank. This is an image of the scapula, so a special view of the scapula, and then also the inferior superior axial view. Now, the Garth view, as shown here, is obtained by angling the X-ray beam 45 degrees. The interior glenohumeral rim and the posterior margin of the suprahumeral head are well demonstrated, and is useful in patients with acute or chronic anterior humeral head dislocations, and also to be able to identify Bankart fractures of the inferior glenoid, as well as Hill-Sachs deformities of the humeral head. Trauma to the shoulder is quite common, so fractures of the clavicle, humeral head, and scapula, as well as dislocations. Anterior dislocations is the most common, but also posterior dislocations of the humeral head, and then dislocations of the AC joint. So when we get back to the ABC search strategy, so alignment, so there's a couple of alignments that you need to check on the shoulder. The glenohumeral joint space should be less than 6 mm. When you look at the clavicle, the inferior margin should be at the level of the acromion, and the AC joint should be less, not greater than 7 mm. With the bone, to exclude fractures, look for signs of steps in the cortex or whether there's a disruption to trabecular patterns. And also exclude other associated fractures, for example, rib fractures, and then in the shoulder, Hill-Sachs and Bankart fractures. When we look at cartilage and joints, check that the joint spaces are well preserved, and also the borders of the humeral head to that of the glenoid. Soft tissue injuries, so interarticular fractures of the humeral head, could also result in a lipohemarthrosis. If we look at some of the common soft tissue calcifications, so we want to look at rotator cuff, and then also with fractures of the shoulder, If there's a fractured rib, you need to exclude whether there's been an injury to the lung, which can result in a pneumothorax. Scapular fractures normally require quite violent force because the scapular bone is so dense. It's associated with avulsion fractures of the acromion or coracoid with either glenohumeral or AC joint dislocations. The important thing with scapular fractures is to check very carefully whether there's any associated rib or clavicle fractures, and if you have rib fractures, then there needs to be exclude damage to the lungs, so you might have to do a chest x-ray to exclude a pneumothorax. Scapular fractures can be associated to the part of the area of the scapula where this has happened. So a type 1 scapular fracture is fractures to the body. Type 2 is fracture to the glenoid rim or articular surface. Type 3 is the anatomical neck, 4 the surgical neck. Type 5 is the acromion, the coracoid, and then type 6 is the acromion, and then type 7 is where there's a fracture of the spine. Clavicle fractures are quite common. It can happen in childhood as well, and the most common mechanism of injury is a fush injury. The middle third is also the most common. However, there is a risk of subclavian vessels or brachial plexus injury. The clavicle fractures can either be undisplaced, they can be transverse, or they can be comminuted, as in this case that we have on this slide. Normally, clavicle fractures are classified into 3 types. So type 1 is of the proximal, type 2 is in the middle, and then type 3 is of the distal third of the clavicle. However, NIA has an additional classification of fractures of the distal clavicle, where type 1 is a non-displaced fracture and the ligaments are all intact. Type 2 is a displaced fracture where the ligaments are disrupted. And then type 3 is a fracture that extends into the articular surface, however the ligaments are intact. Anterior humeral dislocations make up about 90% of shoulder dislocations. The humeral head is dislocated anteriorly and inferiorly. Especially in young patients, it can reoccur, and you also need to search for any associated fractures, such as a Hill-Sachs deformity, which is a depression fracture of the posterior lateral humeral head, or a Bankart lesion, which is a fracture of the inferior glenoid rim. So on this image, on the AP view, you can see that the humeral head lies inferiorly and more towards the middle, and also on the lateral view, the Y view, you can see that it's not, it's more medially and inferiorly as well. So on this image, we can see the Bankart lesion, which is a solid white arrow, and that is on the superior lateral part of the humeral head. And then on the inferior area, we can see a small Bankart lesion, which is the curved arrow. So Hill-Sachs deformities are depression fractures of the posterior lateral humeral head, and it's due to impaction of the humeral head against the anterior-inferior glenoid rim. It's associated exclusively with anterior dislocations of the shoulder, and it's also a sign of previous dislocation. The posterior lateral aspect of the humeral head becomes flattened due to cortical depression. I've given you a link to the article when this was first coined, so you can have a look at when Hill and Sachs described the Hill-Sachs deformity. So here we have an AP view. We can see that the humeral head lies inferiorly and medial, And then on the posterior lateral part of the humeral head, we have the heel sacs deformity. And on this image, we can see on the inferior glenoid rim that there is a fracture, and this is typical of a Bankart lesion. Posterior humeral dislocations are less common. The typical appearance that it has is that of a light bulb. So if we look on the AP view at the top, we can see that it almost have the humeral head is rotated so that the humeral head looks like a light bulb. There's also an increased space between the anterior glenoid rim and the medial aspect of the humeral head. In terms of the mechanism of injury, bilateral dislocations are normally caused either by seizures or electrocutions. A rare type of dislocation is luxatio erector, and this is where the humerus is inferior dislocated. Normally when the patient presents, you should be able to identify this because of the way that the patient holds their arm in the air. It's associated with rotator cuff tear as well as fractures of the greater tuberosity of the humerus. And the AP view is the best to demonstrate this condition. The AC joint, in terms of mechanism of injury, sports injuries are quite common, as well as a direct fall or a fish injury. Your normal AC joint should be between 3 to 6 millimeters. You can compare both sides, and there should not be a difference between the two sides, so it should not exceed 5 millimeters. Now, AC joint injuries dislocations can be identified according to Rockwood classification, and it has a 6-step classification, and it ranges from the clavicle that is not elevated in respect to the acromion to type 6, where the clavicle has now moved inferiorly and is displaced behind the coracobrachialis and the biceps tendons. The rotator cuff comprises a group of 4 muscles that stabilizes the shoulder joint, and that includes the supraspinatus, infraspinatus, teres minor, and the subscapularis. Rotator cuff tears can be identified on plain X-rays, and on the images at the top right-hand side, you can see there's a decrease in the acromiohumeral space, so it's less than 6 millimeter. There's also erosion of the inferior aspect of the acromion, as well as flattening and atrophy of the greater tuberosity. Calcific tendinitis can cause formation of small calcium deposits within the tendons of the rotator cuff, and on the image at the bottom we can see that there is a calcification of the supraspinatus. Humeral fractures are quite common in the elderly, and it affects the proximal humerus especially. In pediatric patients, you could find epiphyseal separation. In adult patients, the most common appearance is at the surgical neck, and then comminuted fractures typically involves the tuberosities. So here we have on the image on the left, we have a fracture of a greater tuberosity. And then on the image on the right, we have a spiral fracture with a separation of the 2 parts of the bone. Pathological fractures are quite common in the proximal humerus. It can be due to metastatic deposits. However, it can also be due to benign lesions such as an aneurysmal bone cyst. So in this case, you can see the large dark area, which is a loosened area, and that is where the aneurysmal bone cyst is. And then on the medial side, you can see that there is a break in the cortex, which indicates that there is a pathological fracture. It's important when there's fractures of the distal humerus that you distinguish whether the fractures are or extra articular fractures, and they are classified here. So we can see in the top row where we have extra articular fractures or transfers just above the condyles, and then you could also have comminuted fractures as well. The lower ones have got the intra-articular fractures, and here you can see Y-shaped condylar fractures as well as comminuted fractures. Now I've included some additional elbow views, and this is mostly to demonstrate the radial head properly. So one of the views is an AP view with lateral rotation, and then the second view is one where the patient's arm is in a lateral position and the tube is angled to about 45 degrees, and this is called the coil method, and it demonstrates the radial head and neck much better. Also important to be aware of the carrying angle, and this is the angle which is formed between the distal humerus and the proximal ulnar, and the normal carrying angle should be about 15 degrees. It's also called Bowman's angle. It is very useful if you want to exclude dislocations or fractures, especially in supracondylar fractures. Now moving on to the elbow. The mechanism of injury includes either push injuries or direct blow or pull of ligaments, and the common fractures that we can have around the elbow is either radial head or neck fractures, dislocations, and then important to differentiate between adult and pediatric fractures, and then also coronoid process fractures. Some of the important image interpretation criteria need to apply to the elbow. So if you want to exclude a dislocation, there are two lines. It's the anterior humeral line and the radiocapitellar line, and I'll tell you a little bit more about that. And then soft tissue signs are important. Elevated fat pads, especially the posterior fat pad, is a strong indicator of an occult fracture if you can't see the fracture. And then when we look at the pediatric elbow, it's important to scrutinize ossification centers so that you don't unnecessarily call that as avulsion fractures. So now when we look at the ABCs of the elbow, so adequacy. Do you need to have additional views, especially if there's a suspicion of a radial head? And then in terms of alignment, the olecranon should articulate with the trochlea and the radial head with the capitellum. Now the lines that we need to draw to assess whether there's any dislocation or subluxation. So on a true lateral view of the elbow, if you draw a line along the anterior humerus, this must intercept with the capitellum at the middle third, and we can see that in the top image. In the image at the bottom, when we draw a line, we can see that we now miss the capitellum, and that is an indication either of a dislocation or a supracondylar fracture. The radiocapitellar line can be drawn on both an AP and a lateral view, and it's an indication of joint alignment. So you draw a line through the center of the proximal radius, and it should pass through the center of the capitellum. So on the image on the right at the top, you can see that's a normal one. However, on the image on the left bottom, you can see that if you draw a line, the radiocapitellar line, it does not intercept the capitellum. The image on the left, the AP view, shows normal articulation. Now moving on to the bones, again check for any breaks in the cortex. Also important to check for the hourglass sign on the lateral view, because that can indicate disruption to exclude a supracondylar fracture, and then examine the trabecular pattern for any changes in density. As this is a joint, you need to look very carefully at the congruity of the articular surfaces, and you do that by checking the radiocapitellar as well as the anterior humeral line, as mentioned before. Now, soft tissues are quite important in the elbow. Elevated fat pads, another name that they use for that, is a sale sign. Injuries that produce intra-articular hemorrhage will cause distension of the synovium, and that will force fat out of the fossa. A visible anterior fat pad can be normal, but normally the anterior fat pad will not be elevated dramatically, and it will only appear as a thin radiolucency. However, when you see a posterior fat pad, this is never normal, and if the indication is trauma, this signifies fluid in the intra-articular space. A positive sale sign in trauma setting is a reliable indicator of an intra-articular fracture. So if you are unable to see a fracture, but you do see that there is a sale sign, so you've got your elevated posterior fat pad, then that is a reliable indicator that this is an occult fracture. Fractures of the radial head is classified according to Mason, and type 1 is where the radial head is undisplaced. Type 2 is where there's marginal fractures with some displacement, and then also when we move on to type 4 now, we have comminuted fractures, and then there is a dislocation as well. On this image, we have a fracture of the radius as well as a dislocation. The clinical indications for this case was a patient who fell on the outstretched hand with a slightly flexed elbow and the extreme pain when the patient rocked up at the emergency department. So what we can see is that there is a comminuted fracture of the radial head, which has resulted in an elbow dislocation. Olecranon fractures are also common. The main mechanism of injury is a direct fall or push injury. They're classified into 3 types. So type 1 can either be an oblique extra-articular of the tip or intra-articular of the tip. Type 2 originates from the middle third of the articular surface, and there you can see it can either be a single or comminuted fracture. And then type 3 involves the distal third of the olecranon. Here we have a comminuted fracture, and also important on this image is that you can see that there is a normal variant, which is a supracondylar process. So in this case, we have a trochlear fracture. So the fracture extends from the lateral condyle to the trochlea, and there is mild displacement, and you will also be able to see that we have a sale sign. This is a 3D reconstruction, so CT can be quite useful, and here we can see that there is a displaced olecranon as well as dislocation of the radial head. Because the elbow forms a ring-like structure with the wrist, forearm fractures. So again, when you have a ring-like structure, there's always the possibility of more than one pathology. So Montague fracture dislocation will involve a fracture of the ulnar and a dislocation of the radial head. And there's 4 types. So in type 1, we have an anterior dislocated radial head with a fracture of the ulnar. In type 2, we have a posterior dislocated radial head with a fracture of the ulnar. In type 3, the radial head is dislocated laterally. And then in type 4, we have ulnar and radius fractures as well as an anterior dislocated radial head. So in the image on the left, we can see that there is a fracture of the ulnar, but if we draw our radiocapitellar line, we will see that there is a dislocation of the radial head, and that's also visible on the lateral view. in the elbow, ossification centers are important, and the mnemonic Crital is very useful to remember. So Crital, the C is capitellum, and then radial head, internal or medial epicondyle, the trochlea, the olecranon, and then the external or lateral epicondyle. And that gives an indication of the ages at which ossification normally appear. And however, this can vary with some patients. But the main thing is that if you know this mnemonic, it helps you to distinguish between an ossification center or whether you are looking at an avulsion fracture. Okay, so on this image, in the first one, so that child was around about 1 year old, we have capitellum, and then we have the radial head, the internal or medial epicondyle. In the image at the bottom left, we have the trochlea appearing, then the olecranon, and then finally the external or the lateral epicondyle. Supracondylar fractures are quite common and occurs at the transverse metaphyseal area. About 15% of these could be green stick. So fractures run transverse above the condyles. They could be displaced or undisplaced. So sometimes they could be difficult to pick up. But however, it's useful to look at raised fat pads and also to check the anterior humeral line. The important thing is that there could be a risk to brachial artery and median or ulnar nerve damage. So on these images, I've drawn the anterior humeral line, and you can see that the anterior humeral line does not intersect the capitellum, so it's displaced posteriorly. And when you look very carefully now, especially on the image on the left, you can see there's a break in the cortex, but also importantly is that you have the elevated fat pads. The Gartland classification is very useful to identify supracondylar fractures. So a type 1 Gartland classification is where the fracture is undisplaced, whereas type 2 fracture is displaced. There's angulation, however, there's still contact at the posterior cortex. And then type 3 is where the fracture is completely displaced and there's no cortical contact. Just another example of an abnormal radiocapitellar line. So we can do that on the AP as well as the lateral view. So on the AP you can see that we do not, if you draw a line from the proximal radial center, it misses the capitellum on both the AP and the lateral. And then on the lateral view as well as in the AP you can see that there is a fracture of the ulna. So with the forearm, the main mechanism of injury is either push or a direct blow. Important to remember that the forearm forms a bony ring-like structure. These injuries can result to either both the radius and the ulna, or it could be a fracture to one and a dislocation of another, or you could have an isolated ulnar fracture from a direct blow. So nightstick fractures, these are defensive types of injuries. It's normally what you would see is a single fracture to the mid-shaft of the ulna, and it is normally undisplaced. So Galeazzi fracture, the main mechanism of injury is a Fuchs injury, and here we now have a fracture of the middle or distal third of the radius, with an associated dislocation of the distal radio-ulnar joint. So with the Galeazzi fracture, really important that you scrutinize the wrist joint very carefully to see whether there is this associated dislocation of the radio-ulnar joint. We have now come to the end of part A. So once you've worked through part A, please go to part B, where I will continue with the forearm, wrist, and the hand.